the Lurie Children's Pediatric Cardiology Roundtable with specialists from our nationally ranked Heart Center. In this session, we'll be discussing sudden cardiac death with the Heart Center's Executive Director, Dr. Stuart Berger. My name is Chad Worley, and I am your Lurie Children's Physician Liaison, and I cover the north suburbs as well as the north side of the city. And if you have questions regarding Lurie Children's regarding referrals or such, you can reach out to us through our webpage at luriechildrens.org/physician services or email physicianservices@luriechildrens.org. But before I send this over to Dr. Berger, I want to encourage you to type in questions in the little question area there. You see it on your right-hand side of your screen as Dr. Berger speaks on sudden cardiac death. So with that said, I'm going to go ahead and pass it over to Dr. Berger, and he's going to go ahead and talk to you about a discussion. But like I said, please type in your questions and we'll discuss this after our session. Dr. Berger, I am going to send it over to you to, you'll see the screen share in a second, and you'll be ready to go.
I want to check in with you to make sure you can see my screen and see it hopefully in the presentation mode. There it is, wonderful.
You're good to go. Have a good session, everybody.
Excellent, thanks, Chad. And thank you all for being on this call and on this webinar. I am very excited about talking about this particular topic. It's one of my favorite topics, I hate to say to talk about, because it's very important. And I think there's information in this that can help save lives. And the topic, as you heard, is sudden cardiac arrest in children and adolescents. I have no disclosures relevant to this topic, and I hope at the end of this 30 minutes, and I think we can get through this in 30 minutes, maybe a little over, and also I have some questions that we can go through. I want you all to understand the incidence of sudden cardiac death in kids. I want you to understand the causes in children and adolescents, and most of all, I want you to understand the role of prevention, both primary and secondary. Is there a way we can intervene and mitigate what is the potential to occur here? I think it's very important to make this statement. Sudden cardiac arrest happens to kids. And I remember when I got interested in this back in the late 90s, and I think you'll hear some of the history of this, at least as it relates to my interest and my involvement, that wasn't so apparent. Some people thought that this was just a disease or an entity of adults and not kids. I think you all know that that's not true, and I think some of the data and experience that I'll show you suggests that. Let me give you a little background in history, and I am going to try, hopefully by showing this video, if I can. I can't seem to find my mouse. And I don't know if Chad will be able to help with that. I'm going to escape that and go back to, I apologize, let's try that. There we go. I want to play this video. It's a chilling video. An elite soccer player. Very chilling and very sad. Again, an elite soccer player, European soccer player, who never had a symptom prior to that, never had a symptom whatsoever, and his first symptom was sudden cardiac death. Many of you, especially if you are sports fans, know that this has happened multiply to elite athletes. I don't know why, but so many of these episodes are with basketball, and I won't go through each of the cases because we won't have time to do that. Somehow, some way, basketball seems to be a big offender or a big instigator, and we can speculate, although I don't know the answer. Up here where my arrow is in the upper right-hand corner is Hank Gathers, and although I do have a video of Hank, I don't think we're going to have time to see that. That is in the next slide. But here again is an example of many elite athletes. Obviously, these stories are big. They make the cover of Sports Illustrated. Each of these kids or young athletes had a different reason for sudden cardiac death, but each of them had some underlying reason for this. I'm going to skip this video. It's a wonderful video to show. It's actually of Hank Gathers and the episode of sudden death that he had on the court, but for the sake of time, I'm going to skip over this. But I do want you to know that this is not only an issue for elite athletes. These are some kids in our neighborhoods and in our schools and locally who we know. Many of these, again, are in the setting of athletics, but they aren't all. And so this doesn't necessarily happen, and I think we all know this by now in 2022, to elite athletes. It happens to kids. It doesn't happen to have to happen always on the athletic field. It can happen at school. It can happen on the playground, and these episodes are the focus of this talk. How do we recognize who's at risk? And if we can't, how do we intervene to make sure that not only does it not happen to the Reggie Lewises and to the Hank Gathers, but to the kids in our neighborhoods and our own kids? Well, first of all, let's review what the incidence of sudden cardiac death is. Remember, I told you that it used to be thought this didn't happen to kids. Well, what's the spectrum of this? What is the scope of this? We have a lot of excellent data on adults. Sudden cardiac death in adults is common, all too common, very sadly. It occurs in about 1 in 1,000 per year. And the reason that adults, especially in America, are at such high risk for this is the endemic of coronary artery disease. It's the disease that happens in adults. It happens with time. And as part of that, sudden cardiac arrest and sudden cardiac death can occur. But what about kids? There is no question that it's less common. It exists, it's less common. But honestly, the true etiology, or I should say the true frequency and incidence, is not known. I'll show you a few studies in a little bit where there is controversy. It is thought in the literature to occur in about 1 to 2 per 100,000. But again, it's multitudes less than the 1 in 1,000. And most importantly, the causes, the etiology in kids are very different than in adults. The majority of causes or etiologies for sudden cardiac arrest in kids are congenital. A few can be acquired, and I'm going to show you the list, I think, coming up of the causes, because it's very important to understand what they are and how they fit in the whole scope of things. I told you that the incidence is not really known. You can pick, or we can pick, a bunch of different studies that'll come up with different numbers. And I won't go through the studies other than to tell you it can be anywhere from 1 to 300,000. And again, it's based on who we're measuring or what we're measuring and how we're getting those reports. Barry Marin reports 1 in 200,000 from insurance claims data. This is an athlete's. John Dresner reports 1 in 67,000 in a survey of NCAA athletic trainers. Diane Atkins in Iowa reports 1 in 27,000. Kim Harmon in Seattle, 1 in 43,000. So you can see there's a wide spectrum here. And there are some ongoing prospective studies that may give us the answer to this. But I think the point of it is that it's not unheard of, and it's not as common as we see in adults. And choose the number that you want, because again, it depends upon how you collect the data and who you're looking at. Many of these are in athletes. But again, I want to emphasize that this is not just aimed at athletes. That the title of this slide is Sudden Death in Young Athletes, but everything I'm going to say applies to everybody. And I could argue, how do you define a young athlete? Is a young man on the playground or in the alley shooting hoops, is that an athlete? I think it's an athlete, and I think those kids are at risk. So I want to emphasize that what I have to say, both in terms of causes and prevention, is not just aimed at elite athletes. It's aimed at everybody, the entire pediatric and, if you will, adult population. So here's what I've been talking about or wanted to show you, the etiologies of sudden cardiac death in children and adolescents. This is a slide that is probably fairly comprehensive. I'm sure we could come up with other causes or other reasons for sudden cardiac arrest in kids, but this is probably the more common. And I'll tell you what the color code is in a second, because it is color coded for a purpose, not just to look pretty. It even looks pretty. All the lesions or all the abnormalities that I listed here in blue are congenital. What that means is that kids have these abnormalities. They may not know it, and they may not know it at birth, and they may not know it ever, and they may not know it actually until they have that first episode of sudden cardiac death or sudden cardiac arrest. The lesions in blue are acquired, including drug abuse, stimulants, commotio cordis. If you don't know what commotio cordis is, I'll show you a chilling video of that in a second. The ones in orange may be somewhere in between. The other important thing to tell you is the ones with asterisks on are not only congenital, but they are familial or genetic, which means to say that these lesions or abnormalities have the potential to occur in families. Why is that important? That's important because if you identify one patient with one of these abnormalities, either because you knew about it or because somebody had a sudden cardiac arrest and survived or didn't, if you're lucky enough to make the diagnosis, it then behooves you to look at every other family member, because you may discover others in those families. And that's a really important point, and it'll become obvious as we talk about some of the cases. This is commotio cordis. I'm going to play this video. Very subtle, but watch what happens. They're looking at his head. They thought he got kicked in the head until they discovered that he had a cardiac arrest. His head. So what commotio cordis is briefly, it's a sudden blow to the chest, and you may have not noticed it, but it wasn't a hard blow, but it was a sudden blow that occurs at the right time in the cardiac cycle. It causes ventricular fibrillation, and it has to be in the right place at the right time with the right velocity, etc. And it is known to cause ventricular fibrillation and sudden death. It can occur in the martial arts. It can occur with baseball. It can occur with lacrosse. It's rare, but it's a well-known, it's a known entity, and it's something just to be aware of. Here is another slide that was put forth by Barry Marin in terms of the etiologies of sudden cardiac death and the percentages based on the diagnosis, again, in competitive athletes. The most common cause is hypertrophic cardiomyopathy, the second most common cause being coronary abnormalities, and all on down the line. And certainly historically, hypertrophic cardiomyopathy is one of the biggest offenders. I want to review for you how I got interested in this concept and way back when, and some of the things that I learned by being interested in this and didn't know before this experience many years ago. And this was many years ago, back in 1999, which would make it 22 years ago. When I was working in Milwaukee at the Children's Hospital, we noticed and experienced a series of sudden cardiac deaths or sudden cardiac arrests in a very short period of time, in less than a year, in southeastern Wisconsin, the Milwaukee area. And I won't go through every one of these here. I think I have examples of that. But over a period of about 11 months, we had 5 episodes in young athletes, young student athletes, of sudden cardiac arrest or near sudden cardiac arrest. And it seemed to me to be odd. I was a young faculty member at that time. I wasn't aware that this was a known entity. I can't imagine, by the way, that this just all of a sudden occurred out of nowhere, but it's something that we noticed. and the etiologies were very different. So for example, the first case was Adam Lemmel in January of 1999. And by the way, Adam is after whom Project Adam is named, and we're going to talk about Project Adam. Star athlete in Milwaukee, had a sudden cardiac arrest while playing basketball on a Friday night. I remember it well. Never really had symptoms. This was his first symptom. Got CPR as quickly as possible, didn't survive, and Adam had a condition that we found at autopsy called arrhythmogenic RV dysplasia. This is not Adam's MRI, but this is an MRI which is representative of a patient with RV dysplasia. If you look at the lateral view of the right ventricle down in the right lower corner, that arrow shows a little bit of a scar up here in the RV outflow tract. And these scars in this condition are either connective tissue or fatty tissue, and they become foci for ventricular arrhythmias. And our presumption is that's what happened to Adam. He had a ventricular arrhythmia and did not survive. Why it took 16 years, nobody will know the answer to that. Next case, a month later, again in Milwaukee, another high school athlete playing basketball. Again, a recurrent theme. Mark, 18-year-old patient playing 18-year-old young man playing basketball, sudden cardiac arrest, CPR, didn't survive. And what Mark had is another condition, a coronary artery condition called left coronary artery from the right sinus of Valsalva. This is what it looked like schematically, and this is what this condition is. This left coronary artery comes from the right sinus of Valsalva, congenital abnormality, courses between the aorta and the pulmonary artery, typically has some narrowing here, we call osteostenosis. And what happens with exercise, because of that constriction or restriction, not enough blood supply gets to the muscle gets ischemic, and you have an episode of ventricular fibrillation. Again, why it took 18 years and he didn't have symptoms before that, nobody will know the answer to that question. Third case, a little later that year, Antonio played at a high school in Milwaukee, playing basketball, recurrent theme, sudden cardiac arrest while playing, actually in a pickup basketball game. He was a football player. His autopsy showed hypertrophic cardiomyopathy. Again, as I showed you earlier, the most common cause of sudden cardiac arrest, sudden cardiac death. I should have had a picture of a normal heart here, but this is a heart with a cross section, and obviously it is an autopsy, sadly, and not of this young man's, but the heart becomes very thickened. And this is more global thickening. You can get asymmetric thickening, but similarly, because of this thickening, the heart muscle outweighs its blood supply, and especially with exercise, is at risk for ischemia and death. Now, these are three cases where the outcomes were very sad, and obviously the kids didn't survive, despite probably what were the best efforts. Are they all like that? Are they all unsuccessful? Well, let me show you a couple success stories and what we learned from those success stories. And I guess you wouldn't have to be a rocket scientist to learn the message behind this. In November, again, 1999, in the Milwaukee area, a little north of Milwaukee, between Milwaukee and Green Bay, young man playing basketball on the playground, again, asymptomatic, but had a syncopal episode. And what that syncopal episode was really sudden cardiac arrest. He was, in fact, as you can see by this rhythm that the paramedics were able to record when they put the defibrillator on him, he was in ventricular fibrillation. I don't know how well it shows up there. And I have some better pictures in a little bit of some rhythms, but this is VFib. Here he gets a shock and you can't quite see it, but begins to return to a sinus rhythm. He got CPR right away. The paramedics happened to be in the neighborhood. I don't know why they were, but they just happened to be there, got there, began CPR, defibrillated him. Remember, this is back in 1999. Defibrillated him 4 more times. He survived. He was discharged. He had full neurologic recovery, and he ended up having the diagnosis of long QT syndrome. And this was his first episode of symptoms. And again, the importance of what I told you earlier, knowing that Craig had long QT allowed us to look in other family members. This is a familial genetic disease, and therefore allowed us to diagnose this in his father and brother. Craig ended up getting, as I said, an ICD. And Craig, to this day, and again, this was 22 years ago, so Craig is in his late 30s, lived to tell the story and to go back onto the basketball court and play basketball. So What we learned, and again, not rocket science, that the survivors, and there were more than one, more than just Craig, got immediate CPR, were all in ventricular fibrillation, and got defibrillated as soon as possible, within 5 minutes, and that led to that good outcome. So how do we prevent this? How do we go forward, and how do I teach and talk to people about, avoiding these pitfalls? And they're not pitfalls, they're just what happens out in the real world. And I think and first of all, can we prevent it? And I want to say the answer to that is yes. And I think just like anything, in order to prevent something, you can do a primary prevention. In other words, you can maybe go out there, find every single child and adolescent who has something that's on that list, whether it's hypertrophic cardiomyopathy, long QT, etc. I think that's going to be difficult to do. I'd love to talk about that at length. I'll talk about it briefly, but we ought to do our best to screen. And if you can't, or if we can't, we need to be in a position to intervene, like happened with Craig, to do CPR, get an AED as there as soon as possible, and change the momentum, or change the trajectory of having sudden cardiac arrest turn to sudden cardiac death. So how do we screen? We screen like we always screen. We take a history, we take a family history, we do a physical exam, and might there be other screening? The answer is yes. I won't have time to talk about that, but there will be other screening, and I'll mention it in a bit. What do we screen for? What could be some signs or warning signs if somebody has them? Remember, I told you all these kids were asymptomatic and didn't have these warning signs, but some kids might. Chest pain could be a warning sign, although most of the kids with chest pain don't have an underlying thing that puts them at risk. Palpitations, certainly syncope with exercise for me is a key warning sign. Shortness of breath. And there are questionnaires that exist for this. I'll get to that in a second. Family history is critical. Deaths at an early age, and you can define what an early age is, and we can talk about that. Unexplained deaths, certainly a known family history of any of those things I put on that chart with the asterisks on is important. Hypertrophic cardiomyopathy, long QT, etc. Physical exam is important. It tends to not be terribly helpful. And many of these kids have nothing on physical exam and don't walk away and say that Berger said the physical exam is unimportant. Of course, we should still do it. Some of the kids may have a heart murmur or a regular heartbeat, but the history and physical and family history is clearly a very important part of this. There are pre-participation questionnaires that exist. The AHA has put forth these questionnaires. Dr. Marin has looked at this way back when. And in honesty, the questionnaires are not that helpful because many of these kids don't have symptoms. And the first symptom is sudden cardiac death. But it's important to make sure that we perform the questionnaires. We ask the question in a very comprehensive and uniform manner. And there was a recent AAP position statement on this that we can refer you to emphasize the importance of doing this in a focused, very specific way and being systematic about it. But you may not pick up all kids by doing the questionnaire. There's a lot of interest out there and always has been about doing other screening, doing routine screening with EKGs and echo. It's very controversial, and it still is. This was stimulated by an Italian study many, many years ago that suggested in Italy there was a 90% decrease in sudden cardiac arrest by doing EKG screening, with the incidence of HCM and ARVD being much higher in Italy. This has been argued with studies that have not shown the same thing by Berger Marin and Sami Viskin in Israel. Suffice it to say that this debate rages on. There are a lot of logistic questions about cost, normal values, who reads the EKGs, false positives, false negatives. So let me suffice to say that I could talk about this part of this for another hour or longer. Most people believe it's not quite ready for prime time to do EKG screening in the United States in terms of the efficacy and in terms of the position and able to do this. So we can talk more about this, but this is a topic unto itself still with controversy. I want to tell you most importantly, because we're running out of time, I know I can go over a little bit, Chad will allow me to do that, what we had done in southeastern Wisconsin way back in 1999 when we were confronted with all of these cases and scratching our heads and saying to ourselves, we just can't sit by and watch this and wait for more of these cases to occur. We developed a project called Project Adam, which started in Wisconsin. I'm very happy and proud to say it is gone well beyond Wisconsin. ADAM stands for Automated Defibrillators in Adam's Memory. I showed you that first case of Adam Lemmel. It was an initiative to prevent sudden cardiac arrest and sudden cardiac death. We began it that year, November of 1999, and it's at least a school CPR AED program. The goals of the project back then, and by the way, they haven't changed now 22 years later, was for education and awareness of issues around sudden cardiac arrest, sudden cardiac death, advocacy for CPR AED education for every single student before graduation, advocacy for CPR AED programs in all the schools, and advocacy for a cardiac emergency response plan in every single school. The goal is to eradicate sudden cardiac death through school and community prevention. I am very, very proud to tell you after 22 years, having started in Wisconsin, we now have programs in 26 states. Some states have more than one program. So we now have 34 programs in 26 states and growing. The majority, but not all of these programs are based at children's hospitals. We have felt that having the expertise of pediatric cardiologists, pediatric electrophysiologists really allows the basis of this program and the basis of the program's growth. Here are the logos if you're interested to look at some cool logos of all these children's hospitals that have been such a critical part. And I'm very happy, needless to say, to tell you that Lurie is a huge part of this. But look at this. This is the amazing part to me. With the partnership of all my friends and colleagues at all these children's hospitals, we have had over 200 saves in the schools per se. And by the way, these are not only saves of kids, as you can imagine, because I told you adults are much more likely to get this. Adults have sudden cardiac death. Adults are much more likely to reap the benefits of a program such as this. So throughout the schools of the 200 plus cases, about 60% of the saves have been adults, 40% have been kids. It's amazing. In my wildest dreams, I've never predicted that. And I would bet, although I can't prove it, and I don't need to prove it, that many of these cases would not have resulted in survival had these programs not been on site and with immediate intervention. A couple of examples of this as I finish up, and this was back in 1999 as we were understanding all of this. 14-year-old girl in the Milwaukee area, recurrent syncope with basketball. Every single time she ran up and down the court, she passed out. Her grandmother called us and said, this just doesn't seem right. In fact, we saw one of our local primary care providers, and they told us, remember, this is back in 1999, they told us, don't worry, it's normal for teenage girls to pass out. Everything will be okay. Well, it can be not so abnormal in the setting of neurocardiogenic syncope, but she didn't have that. She had a left coronary artery that was arising from the right sinus of Valsalva, and this grandmother got her to the heart center where we could make the diagnosis and she could go to the operating room for an operation, because I think she was at risk of sudden cardiac arrest. And sudden cardiac death, I should say. And I think each one of these episodes, each one of these episodes, in fact, was with this ischemia or this coronary artery acting funny. Another great case, 2004, Jonathan in Kenosha, which is a little bit south of Milwaukee, playing a football player in the weight room before Christmas, got up, lifted weights, passed out, and collapsed. The trainers and the coaches got there immediately, began CPR, called for an AED, which Project Adam put there. And this is Jonathan's EKG. Clearly a better tracing than before. Ventricular fibrillation. He got one shock, literally within a matter of 10, 15 seconds after they put the defibrillator on him, and returned to a sinus, to a perfusible rhythm, and survived this. Interestingly, again, Jonathan had long QT syndrome, and we had discovered that his mom, who died 4 years earlier, also had that, and looking at her EKGs, and a sister and niece had it, and we were able to intervene. Last set of slides, and I promise I will be finishing up after this, but this is really important. You could argue that, okay, so what? You've put these devices in, maybe these lives would be saved, maybe they wouldn't. Is there data to show that school CPR AED programs are effective in saving lives? This was a study done by a dear friend of mine. I mentioned his name earlier, John Dresner, who is a family practice doc, sports medicine doc in Seattle, where he prospectively looked at over 2,000 schools that had CPR AED programs prospectively, now not retrospectively, over a 2-year period, with the primary outcome to be survival to hospital discharge. He wanted to know if you had a CPR AED program in your school and you had a cardiac arrest, did it make a difference? Here is the data, which I think is incredible. This is survival following a sudden cardiac arrest if you had a CPR AED program in your school. Let me tell you before I show you this data, although here it is, the outcomes from out of hospital cardiac arrest are miserable, are dismal. If, for example, somebody had a cardiac arrest out on Chicago Avenue, the outcomes are probably a survival of about maybe 20% at best. It depends upon how quickly you get there. But in general, they're less than 50% depending upon where they are, and they could even be less than that. This data shows in a school, if you have a cardiac arrest and you have a CPR AED program, here are the numbers. And in fact, if you're a student athlete or an adult exercising and you have a witnessed cardiac arrest, and of course CPR, the implication of CPR and AED use occurs immediately, you have almost a 90% chance of survival. And that is so different what's out there in the community, which again shows that this is a very focused scenario, very focused environment where everybody is tuned into it. You have AEDs on the wall, people know CPR. The question is, can we reproduce that in the community and get something better than the 20% that we have? And I want to think that the answer to that is yes. So let me summarize by saying that what we have learned, and again, there's a lot more we can talk about, and I hopefully will still have answer to some questions. Sudden cardiac arrest in the school setting is relatively uncommon, but it occurs and it is devastating. I didn't mention that, but it's clear that if any of you have ever experienced this, it is just horrible. It is beyond horrible. There's not a lot of evidence in terms of the studies with regard to the frequency or the incidence, but it isn't zero, and I think we have shown many examples of that. The interest and demand for school CPR AED programs requires that we organize this and do this in concert and do this in collaboration, and that is really critical. And we do it in collaboration with a school emergency preparedness plan, which every school should have. They could be different for each school and probably will be. And that the CPR part of CPR AED is critical. I truly believe there's a benefit to training a community of individuals who can perform CPR and use AEDs. And I think John Dresner's data proved that. School CPR AED programs will save lives, both kids and adults. And we should do it the right way and include everybody who is interested in this, parents groups, cardiologists, you name it. Anybody and everybody should be involved with this, because only as a community will we be successful. We already have been, but I think we can even take it to the next level. Let me show this last video.
It's a common complaint among high school students that stuff they learn in the classroom doesn't have much real world value.
Like the transformation factor is like the number you'd multiply to this to get that. Also true.
Last Thursday night, 16-year-old Lindsay Paradise poked a serious hole in that argument.
I was sitting, I think it was like section 5 right here.
Lindsay and her mom were among those packed into Fridley Gym watching the boys basketball team take on Simley. With 5 minutes left, one of the officials, 49-year-old Dale Wakasugi, fell to the floor.
We've had officials blow out a knee or twist an ankle, which, you know, you see him taking off on a carpet. Never this.
The ref had suffered a serious heart attack. Lindsay ran onto the floor, and with help from 3 adults and CPR training she had just finished up in health class, she went to work.
It was crazy. Like at first when I saw her run down there, I was like, you know, get out of there. But then I realized, you know, she knows what she's doing and she can do it.
When 3 rounds of CPR failed to revive him, someone grabbed one of the school's automated exterior defibrillators. Lindsay ran through the steps and push the button.
I could see his stomach going up and down after that, so I knew he was coming around again.
God sent her to be there in that place at that time for a reason.
Dale Wakasugi left the hospital knowing he owes his life to a simple yet amazing machine and a teenager who was not afraid to use it.
So many things had to happen for me to be alive, and they just all fell into place.
Sorry about the choppiness of that, and sorry for going over, but that's a very compelling video, and these examples have been repeated multiple times. It's just amazing what kids and adults can outdo out there in the schools. So thank you. I am sorry that I went over. I'll leave it to Chad to see if we can answer some questions either now or later, but I really appreciate everyone's attention. I love this topic, and I think this is an example of how we as a community can really make a difference. So thank you all very, very, very much.
And thank you, Dr. Berger. That was compelling, engaging. You were great, and I think that there's a bunch of questions here that we can get right to. So Dr. Herrenberg writes, so say there's a positive family history of WPW. How young and what age do I work up or refer young kids?
I would probably, can you hear me okay?
Yeah.
I would for WPW, I would probably get an EKG early because it's relatively easy to do. I think you probably will have to repeat it at another point because sometimes in particular for WPW, you don't see it right away. And I think the same is true, by the way, for hypertrophic cardiomyopathy. If there's a family history of HCM, getting an echo early, as early as reasonable would be an important thing. But sometimes it progresses over time. I've had examples of kids in my clinic who have a family history of that. You can do an echocardiogram, it's quote unquote normal, and then 2 years later it's not. So depending on a particular lesion that you're dealing with, you may have to look again. But I think getting a baseline early is never a bad idea, especially if it at least is starting with an EKG.
Great. Dr. Anna Lofter writes, can you please clarify age thresholds for pertinent family history members if they exist?
I'm not sure I understand what age thresholds. You mean when the family history becomes important? I don't know if you can clarify. I apologize for not figuring that out. Asking the questions about, I think asking questions about family history, I think you can always ask, but I'm sure that's not what you're asking.
Dr. Lofter, I unmuted you if you want to ask the question live.
Oh yeah, please.
We'll give her a moment.
I'm sorry
that we're going to go ahead and move on to the next. Yeah, that's okay.
Please
move on to Dr.
My number, Chad, because she can call me directly also if she'd like.
I sure will. It's also on the screen, everybody. You could see real quick, Dr. Berger's information is right here on your screen. You'll see his phone number and his email if you'd like to reach out to him. Dr. Rebecca Unger writes, with a positive family history, do you recommend just getting an ECG or a referral to a cardiologist?
I think a positive family history of a specific underlying disorder would certainly allow you to determine, do you need an EKG or an echo? If it's a positive family history for sudden death, I think I would probably get more of the details of the history and either have a chat with the cardiologist and then probably end up having the patient go. But I think go to CS, but I think it depends upon the specifics of that positive family history.
Sounds good. Okay, so that's about it for the questions right now. Dr. Lofter did write, and we're having some issues getting her unmuted. So I'll pass on her email address to you, and you guys could have a conversation.
And we can talk in person. We can talk on the phone also.
That'd be great. Dr. Berger, you and I didn't discuss this earlier, but you know, one thing we have on folks that are on the line is I want to let you know that we have a brochure handout to download if you want to, and it's our priority second opinion clinic handout. And can you just touch on that real quick, Dr. Berger, because we know it's such an important part of our heart center here. Can you talk about that? Just like, you know, give us a quick cliff notes on that one.
Sure. We see a fair number of patients for second opinions, and it's often driven by pediatricians. It's often driven by families themselves who would just like us to review the data, and sometimes we do it virtually, especially if patients are from far away. Sometimes we do it locally, and we're always willing to do that. Let me reassure all of you that it's not an attempt to get the patients to come here. It's an attempt to give the community a second opinion and an answer. We work very well with our colleagues across the city. So it can be over the phone. Sometimes it's important to review, more often than that, it's important to review the data, echoes that have been done previously, EKGs, but it's a service that we love to give and help the primary care givers in the community as well as the families. So I think Chad can get that number, but if there's ever a question and we can help in any way, we're more than happy to do that.
Absolutely. Well, I think that wraps it up. Thank you, Dr. Berger, and thank you, folks, everybody who's joined us this morning to hear Dr. Berger's talk on sudden cardiac death. I'd like to invite you to join us later today at 12:30 as Dr. Batista will be talking about preventative cardiology, and then tomorrow we will have 2 more discussions, and Thursday 2 more discussions. Lots of you are registered for those, so I hope to see you on tomorrow. And please pass this on to your colleagues, as these topics are obviously very important in pediatric cardiology. But until 12:30 today, I like to say goodbye, and we'll see you soon. Have a great day, everyone. Thank you, Dr. Berger.
Thank you. It's a real pleasure. Anytime. Take care, everyone.